I think the patients with unresectable locally advanced disease, stage 3 disease, is probably the most heterogeneous patient population we see in the world of lung cancer treatment. At our institution, these patients are discussed extensively at our multidisciplinary tumor boards. Our surgeons, our radiation oncologists, our radiologists, our medical oncologists, everybody, pulmonary, participate in these discussions because this is a unique group of patients as far as I'm concerned. They could have more comorbidities either as a result of just medical history or by virtue of having locally advanced disease. Some of these patients are really symptomatic, and I think this is one area where we do really absolutely need a multidisciplinary approach to the management of these patients. It is a rare patient with locally advanced disease, at least at my institution, where they're not followed by a pulmonologist, they're not closely monitored by medical oncology, radiation oncology, all of those. And I think it is that multidisciplinary approach that makes aggressive treatments like chemo-RT followed by durvalumab possible, because, again, these patients could have numerous toxicities and issues that requires that sort of a close management and follow-up. So to me, durvalumab is an enhancement over and above what we've been doing. I think it is, for me, the standard of care. Again, I will discuss and offer it to most of our patients that I think are eligible for it, but I would not sort of go on my own and treat these patients without having the multidisciplinary team involved to help me manage all of the aspects of the care of these patients. So PD-L1 and stage 3 locally advanced patients has become a little bit controversial. So let's take it one by one and sort of go over the issues. One, and I've had these discussions with my colleagues, and people are either one side or the other side of the argument. So why is there a controversy? In an unplanned subgroup analysis requested by medical authorities in other countries, the investigators for the Pacific study went back and looked at the impact of a PD-L1 expression on the clinical utility of durvalumab after chemo-RT. In this unplanned subgroup analysis, and I again have to emphasize this was an unplanned subgroup analysis, patients with negative PD-L1 expression, basically less than 1%, did not seem to have the same overall survival benefit from durvalumab that patients did with higher levels of PD-L1 expression. This has raised the question of whether we should offer durva, which again, is a checkpoint inhibitor, could have potential toxicities, to a patient population, meaning those less than PD-L1, less than 1%, that could not benefit from them. I think it's a valid question, but I hate to make a decision based on a subgroup analysis, an unplanned subgroup analysis. And the reason I say that is because in the intent to treat patient population, meaning all comers, the study is clearly positive for the use of durvalumab following chemo-RT. I think for those patients that have a PD-L1 expression less than 1%, the medical oncologist who would administer the durva should have a very clear, open discussion about the data with the patient to let the patient know that based on this subgroup analysis, there is a possibility that they would not benefit from the use of durva. Not only that, but also the fact that A, they could be responsible for some copay, and B, that they could suffer an immune-related adverse event because it is a checkpoint inhibitor. And I think with the well-informed patient discussing all the caveats of the subgroup analysis, I am comfortable with offering durvalumab at this point to that group of patients who walk into my clinic. So I do check PD-L1 expression, and I use it as a point of discussion again with my patients. In the case that we have, this patient has PD-L1 expression that's well over 1%. So I don't think there is much of a discussion in this case. But in the case of someone with less than PD-L1, less than 1% PD-L1 expression, I think that does deserve the discussion with the patient. And I think this is an area where we need additional studies to really, in a well-designed, randomized fashion, try to figure out if truly PD-L1 negative patients are not going to benefit from the use of durvalumab. So again, I think it's a little bit controversial. We do need more data, but I tend not to make those kinds of decisions without a clear discussion with the patients when the decision is based on a subgroup analysis that was not planned.